Got quite a few folks on. I think we can probably go ahead and get started. Just so you know, we post these online. Most of you guys probably do know that already, but I got a text or an email from some guy in India that said he's looking at these and that it's really helped him. So people are learning from what you guys are doing. Who wants to give this one a go here?
Hi, good morning, Dr. Cockerell. My name's Annie.
Hi there.
I can do the first one.
Okay.
So it looks like we have a shave biopsy.
Yeah, too bad. I wish we had a bunch of this, it'd be better, but that's okay.
Just looking at it, like deciding between like inflammatory versus neoplastic. I lean towards neoplastic. It looks like there's a lot of these like aggregates of cells. And then in making the decision between malignant versus benign, when looking at it on low power, it looks like some of these cells had abnormal mitoses, so I lean towards malignant.
Okay, yeah, and we got a shave biopsy of something that's bigger, and we don't know really the size of this thing or how deep it goes or anything like that. So yeah, I mean, when I looked at it, I sort of said that low power, it looks like it's comprised of possibly inflammatory cells. It's sort of hard to tell here because these cells are kind of pale. So, well, gosh, they're pale. Are they epithelial cells? Are they histiocytes? Something's going on here. It's also the cornified layer. What do you think about this? What do you think this thing would have looked like clinically?
Yeah, well, it looks like we have this like area of like focal like perikeratosis. So clinically, it was probably an area that was more irritated or raised compared to the skin surrounding it.
Yeah, it kind of looks like a papule, and it's got all this crust on it. So you can imagine that it would be really crusty, and it's got some erythrocytes in there. So it might even look kind of black. Whenever you get a hemorrhage in the cornified layer, or you get a scab, like if you skin your knee, it kind of turns blackish when the red cells sort of gradually degenerate there. So it probably had a dark, crusty kind of color to it, which is characteristic of this entity. So if you said it's neoplastic, you think it's epithelial or non-epithelial?
Well, it looks like a lot of the neoplastic or group of cells is kind of happening more like the DEJ junction. So it looks like it kind of starts evolving like the epithelial.
So you think an epithelial neoplasm? Okay. So if it's epithelium, which kind of epithelium do you think it's recapitulating?
Well, it's like
epithelium,
yeah,
right?
it's like the top part of like the papillodermis, but also like the DJ junction is like the stratum basale, like the most bottom layer of the epidermis.
Well, do you think that? So is this what you think is a neoplasm right here?
Yeah, there's these like aggregates of like cells that like have really like a lot of cytoplasm. They're really like pale pink, and like you can see like a lot of like the nucleoli.
Okay, so you think that they might be some type of epithelial malignancy that maybe it's not a contiguous to the epidermis, so it might actually, what do you think, maybe secondary or something?
Possibly.
Okay. What about these cells here? You looked at those. Can you tell anything about those cells right there that I'm kind of pointing to? I agree that a lot of these cells have abundant cytoplasm, kind of like, and we'll talk about what that is in a minute, but what about these other cells in the background here? This dark hyperchromatic cell here, another one's kind of got almost a reniform nucleus, another one's hyperchromatic. What about these kind of cells?
I was thinking that those are possibly like, it looks like these like spindled cells, like possibly like also like the like mitotic figures with the really dark and abnormal like shape.
There are mitotic figures in here, but do you think these are spindle cells here? Spindle is going to look like like a long sort of thin, like a spindle, like a needle, if you will. These kind of look to me more kind of round, and they're pleomorphic. They vary markedly in size and shape. This one's small and dark, and this one's large with a more open chromatin. Some of those cells you noted at the top, had abundant cytoplasm, and so they're not. It's really a very pleomorphic infiltrate. And I do think that there may be some epidermotropism of some of the cells. as you pointed out. And the reason it's crusted like this is probably this thing was ulcerated. Whenever you see like a really thin epidermis like this with the face of the epidermal reedy, there's really kind of two ways of that happening. One is you get inflammation that just destroys the epidermal reedy. The other is that you've had like an ulcer or a subepidermal blister that's reepithelialized. And given that there's all this crust up here, and these atypical cells are even in the crusted area there, it probably was necrotic or ulcerated, and then it reepithelialized.
Mm-hmm.
Well, what if I told you these were lymphocytes, that these were not epithelial cells, that they were atypical lymphocytes here? Would that help you with potentially diagnosis?
If it's like aggregates of lymphocytes, since they're all like, it looks like there's like a lot of inflammation, I'm not sure what the exact diagnosis would be.
Okay. So it's an atypical lymphoid infiltrate. It's a papule, at least looking at it kind of at low power. It looks like a dome-shaped papule. Probably was necrotic centrally with this serum crust up here with perhaps erythrocytes in here. And the cells are really strikingly atypical, very, very pleomorphic. So some of your more senior colleagues might have some ideas about what the diagnosis might be. Or they might say, well, I'm not sure, but here's a stain I might want to do. So if you had a differential diagnosis of this being maybe a lymphoma or something like that, what kind of stain might you put on this to try to help you define the diagnosis more specifically?
Yeah, I think for us, potentially melanoma was on the differential, just based off like the aggregates of cells. So we could do like an S100 to see if it's like a melanocytic in origin.
Good. That's a good idea. I think you should almost always consider melanoma whenever you're doing an atypical malignancy, because melanoma can do just about anything. And so, yeah, let's say we did that and it was negative. So it wasn't a melanoma. What else would be in your differential? So you think it's malignant, which is good.
Mhm.
And you're thinking it's malignant largely based on the cytology of the cells. So an S100 protein might also highlight, let's say if this were like a really bizarre case of Langerhans cell histiocytosis. And in this case, it was negative for that. So that's not the marker that it was highlighting. Notice this epidermotropism up here is a pretty good example of it right there.
Mhm. I think potentially other things like on the differential would be something like lymphomatoid papulotosis. We could stain like CD30.
Yeah, good, excellent. That is what this is, by the way. So this is CD30. This was a CD30 positive example of lymphomatoid papulosis. So that's good, excellent. So, and you can tell low power, it's kind of got the architecture that you would expect to see with that. It's a papule. The cells in lymphomatoid papulosis there's about 6 different subtypes now that they've described. The classic ones that we used to see years ago before people split out a bunch of those was usually a superficial and deep infiltrate of really super atypical cells. This one does have almost kind of a histiocyte population, which is kind of interesting. That's a little bit of an unusual finding in lymphomatoid papulosis. Most of the time, they're very strikingly atypical lymphocytes with you get eosinophils in the infiltrate. They usually do often ulcerate, and they can give you like a black sort of eschar on the top of these lesions. If you've seen it clinically. And again, there's several other subtypes. There's a type that can look very much like mycosis fungoides with a more of a band-like infiltrate. You can get CD30 positive transformation of mycosis fungoides. So that's always in the differential diagnosis of this. And you can develop, interestingly enough, patients with MF can get lymphomatoid papulosis. That's a separate sort of condition. So they have known MF, they're smoldering along, everything's fine. And then they start getting papules. And you have to like make sure that you don't overcall that transformed MF if they're just getting a coincidental coexisting lymphomatoid papulosis there. You can also get lymphomatoid papulosis with other types of lymphomas, Hodgkin's disease. So, you know, there's about 6 types. There's some that give you very strikingly anaplastic cells, or some type that there's one type that gives you very cerebriform cells. It looks kind of like the B type. It looks like, I always think of B looking like a brain, cerebriform. The A is the really anaplastic type. This would probably be more the A type because these cells are super atypical and very pleomorphic. So I think if they gave you this on the board examination, they probably would give you some information and said this was, what stain might you do on this, and you might think about doing a CD30 stain, or they might give you this and say CD30 was positive here. What's the diagnosis? And then give you kind of a list of things to know about. Anyway, that's a good example of one of the variants of lymphomatous papulosis. I don't think you need to worry about knowing all of the subtypes. That's kind of more for the dermatopathologists. If you just know the general fact that this lesion is a CD30 positive process associated with underlying lymphoma and mycosis fungoides 15% of the time, and they can also develop vasculitis some cases as well. So that's a good example of that. Okay, a little different kind of situation here. Anybody want to give this one a go?
Hi, Dr. Cockerell. My name's Yelena. I'll be going for this one.
Okay.
All right. So we see here we have a shave biopsy of what looks like a very kind of nodular structure. It's very round, well encapsulated, and just kind of looking at it from
a shave biopsy though, like the last one was clearly a shave biopsy.
Yeah.
There's actually 4 different kinds of biopsies, and people tend to forget about the last one. We have, shave. I'm not even going to put curettage in there because that should be more of historical interest. I mean, some people do curetages, shave, punch, excision or incision. And then the last one that people tend to forget about, but you do it a lot in the clinic, is what we call enucleation. So when you see that come in with those pilar cysts on the scalp, and the best way to treat those, you just make a little incision over it, and then you just push on it and it just kind of pops out. And when they pop out, you don't have any epidermis there anymore because the epidermis is still there. This was like sitting beneath the epidermis, and it probably felt like a little marble or something like that.
Agreed.
What do you think they submitted this to us for our differential diagnostic list when they put that on their rec slip?
Well, I think that it probably was submitted as like cyst versus other, or
Exactly right. Because when things pop out, dermatologists say, well, that's popping out just like a pilar cyst, so it's probably a cyst. I mean, they're using that as a diagnostic criterion. And just so you'll know, a lot of times things that look like cysts are not cysts. All sorts of very dangerous lesions that we think are cysts, like metastases, desmoplastic melanoma. I've seen 7 of those over the years submitted as cyst by very, very good clinical dermatologists that were fooled. So whenever something comes in as a cyst, or you think it's a cyst, don't just get cavalier with it. Most of the time it is, but every now and then you're going to be fooled. And it's going to be metastasis, or it's going to be something like this, which clearly isn't a cyst, right?
Right.
Good. So what do you think this is?
So do you want me to tell you right away, or do you want me to describe what I can
work through it so the people from India know what your brain thinks?
Sure. So from low power, we can see some hypercellular areas and other hypocellular areas. As we kind of continue to zoom in and look on a higher power, those hypercellular areas seem to resemble Antony A tissue. And there's some spindle cells that line up in parallel rows. And yes, and those are called Verricae bodies, the regions without the nuclei between the palisading. We can also see some hyalinized vessels.
Okay, good. So basically you're describing some of the classic features of what entity?
A schwannoma.
Right. I'm not seeing as many Verricae bodies in this one. Sometimes you get a lot of Verricae bodies, and it's not as critical as to whether they're Verricae bodies or not. Some of them you'll see way, way better than this. I mean, you'll see some that really, really look like 2 little armies lining up across an acellular field. I always like to think it's like the Trojan War, where you get, this is probably kind of a weak Verricae body there, and usually what will happen is you'll get these Schwann cells that's kind of line up here, and then you get an acellular and another one over here, and they're getting ready to charge across at each other. So there are a couple here, but there aren't that many. So, but if you go back to low magnification, though, there's got some other nice teaching components to it. It's obviously very It's relatively small. It's very, very symmetrical. It's very, very well circumscribed. And so it's got all the features of the benign process. And then you say, well, is it epithelial or non-epithelial? If it's epithelium, it doesn't look like squamous epithelium or anything like that. So you go to higher magnification, say, well, maybe it's possibly neural. Now, you saw the Verrucay bodies and you saw the hyaline blood vessel linings. What about the cytology of the actual cells made you favor this being nerve, say, versus muscle?
It looks like spindle cells.
Okay. And well, what about, say, for like a fibrohistiocytic process? I mean, that's also a spindle cell lesion. What are the shape of the spindle cells in a schwannoma or a neurofibroma or a neural neoplasm usually? What are the shape of the nuclei there most of the time?
They're kind of wavy.
Yeah, you've got a kind of lazy, wavy S shape. If you're looking at something like a fibrosarcoma, for example, or something where there's mostly fibrocytes and histiocytes, they tend to be more angulated and they kind of like make sharp curves, if you will, left and right, 90 degrees. These tend to be more kind of lazy S, like the lazy river kind of thing that your kids go to. And then there's also mucin in this, and I think a lot of this is kind of a mucinous degenerated stroma. And then you mentioned those thick hyaline blood vessels. That's also a fairly characteristic entity or finding in a schwannoma. So how does a schwannoma develop versus say, a neurofibroma? If you wanted to sort of teleologically tell us how a schwannoma really develops.
I know that a
schwannoma.
So I know, like on histology, the neurofibroma is more of a mixture of cells and not as kind of uniform as the schwannoma. But as far as how they develop, the Schwann cells, I know that they make myelin for the peripheral axons. So maybe the neurofibromas they're more central.
Well, they both actually sort of arise from they're both of the same type of cell because they're both Schwann cells, Schwannian in order, a lot of axons. But a schwannoma or a neurulomoma, it usually comes off of the outer portion of a pre-existing nerve. And you can see the pre-existing nerve here. So it's almost like, it's like a knob on a tree. So this is the twig, and this thing is just growing off of it, if you will. A neurofibroma actually comes from the middle of the nerve. So you almost never will see a nerve twig like this to the side of a neurofibroma. So you can kind of think of if a little miniature person was walking inside this nerve and they had a hand grenade and they exploded it, and all those Schwann cells became, they comprise the entire lesion. Well, that's how a neurofibroma develops. If they set off the grenade up here, and that's what caused the Schwann cells to kind of proliferate, it's coming off of the outer part of the nerve. So just think of it that way. They're two different, they're the same type of Schwannian lesion, but one kind of comes off of the outer part of the nerve twig, and the other comes off from the central part of the nerve. So that's kind of where you get plexiform neurofibromas. You can sometimes get plexiform schwannomas, but they're less common. These are usually just a solitary little lump like this. It's almost like a lollipop. Here's the pre-existing nerve, and here's the schwannoma coming off the top of it. So it's really kind of cool that we actually have that little peripheral nerve in this one here. But that's very good that you were able to diagnose that. I mean, it's a pretty classic lesion. I don't know that the board's going to ask you a lot about the difference between Antoni A and B. The Antoni B generally tends to be more myxoid and doesn't have the classic Verrucay bodies. There sometimes can be a little overlap. I'd probably say this one would be kind of somewhat of an indeterminate version because it's got a couple of the Antoni A areas, but they're pretty subtle. All right, very good. So we actually have a little bit of a theme here today. There we go. Anybody want to do this one?
Yes, good morning. My name's Ellie. So starting off, it looks like we have either a deep shave of a pedunculated looking lesion.
Good, excellent. What part of the body do you think we're from here?
So I noticed that there's a lot of hyperkeratosis, and then there is this, thin clear layer in the epidermis, which is the lucidum. So I was thinking this is one of the acral surfaces, either the hand or the foot.
Good, perfect. That's exactly right. And so that's a good clue because this entity that I'm sure you're going to know what it is occurs in that location very commonly.
Yes. So the next thing that kind of pops out to me is, I guess we did skip step. I did think that this was kind of more under the like neoplastic
Good.
benign category. And then what pops out to me most is this bundle of cells in the center here, kind of on low power. They look more hypocellular. And then when we zoom in, I felt like they resembled kind of nerve tissue, like we were previously discussing. They're very spindly type cells.
Okay. So you think this is benign, obviously.
Yes.
So in other words, if we drew a line right down the middle of it, it looks very, very symmetrical. And
Yes.
notice how vertically oriented it is also. That's another clue to benignity. If something is kind of vertically oriented like that, that's benign. So symmetrical, very small, it's tiny. And then is epithelial or non-epithelial? Well, is nerve epithelium, it's neuroectoderm, so maybe, but it's more, you're right, it's more of a spindle cell process. So it's neural. Now we just had the schwannoma.
Right.
That's what this is. Is this the same entity?
No. Because of where it is on the body and kind of how it's more pedunculated, I was thinking that this was an accessory digit. But we talked about how possibly they're on the differential, we would include acquired digital fibrokeratoma.
Okay, there's kind of it is probably what people call an accessory digit, but what do you see if we cut off your finger, if you had an extra finger and we put it in formalin and submitted it, what do you think it would look like?
There would be more bone.
Yeah, there should be cartilage,
Mm-hmm.
like a baby, or like bone that's developing, but we don't see that here. So what
Right.
do we see here?
We just see the nerves and kind of like collagen and
we talked about those lazy S kind of shaped nuclei. This is a beautiful example of that here.
mm-hmm.
Look at that. It just looks like it's just wavy like this. And these nuclei are they're thin. They're just kind of flowing along in that little canal that's at, what is it, Great Wolf or something like that. So it looks a lot like that. So these are nerves. And so it is an accessory digit. It's kind of what's left over from it. But what's the remainder here? What are we really looking at here? It's not really, doesn't have all the components of a digit. It's just got the nerves. So what happened here? How did this develop?
So my understanding is that it just that when the baby was born, there's an extra digit, and then the body kind of tries to like send the nerves there, which is why you get the nerve bundles.
Well, what's kind of thought to happen is that when the baby's still in the womb, for one reason or another, maybe an amniotic band or something like that, kind of somehow this thing gets amputated in the womb, and then it forms a traumatic neuroma. And so this is a little residual traumatic neuroma. You can see there's some fibroplasia surrounding these areas here. So there's fibrosis, there's these axons here. So these are mostly axons. So being Schwann cells like the neurofibroma and the schwannoma, here you've actually got axons. So if you actually did a stain for neurofilament, it would be positive here highlighting these cells. Now there's probably some Schwann cells in here also, but the bulk of these are axons. So basically what's happened here is that there's been a traumatic amputation of that little accessory digit. And then the nerves that are involved in that thing start regrowing and they form this little traumatic neuroma. So we call these accessory digits, but when you biopsy them, they often just show this little residual traumatic neuroma that's left there. So sometimes you'll actually see bone and cartilage and all those kind of elements in there, and it really and truly does look like a finger. We sometimes even see a little teensy fingernail and natricle. But here we just have this fibrous area. Architecturally, it kind of looks like a wart, and then you biopsy and it's got all these little irregular nerve twigs, nerve fascicles here that never really reformed properly. So this would be analogous to what you would see if you biopsied somebody that say they had a traumatic amputation of their leg and they got a little papule biopsy. You see the same kind of thing. Looks a little bit different than Morton's neuroma. That's where especially women that wear high-heeled shoes for long periods of time, they kind of get a gradual, slow, ischemic destruction of the nerves, and you get a lot of fibroplasia that just encompasses the actual nerve twigs, if you will. And those are really quite painful. So, and this lesion sometimes is painful too. So in your mnemonic England or Bingle or whatever you use to remember that, the N is neuroma. You know, it's not neurolemoma, which is a schwannoma. Those are usually painless, and neurofibromas are painless, but these lesions are painful many times because those nerves aren't working properly. So that's great. That's exactly, this would be, if you call this rudimentary digit, you're absolutely on target. That's what they look like.
Thank you.
Great. Okay, this is kind of a cool little lesion here too. Let me get it to work.
Good morning, I'm Rachel. I'll take this one.
Okay.
So at low power, we see we have a shave. Immediately, we see this kind of well circumscribed proliferation of cells forming like a dermal nodule.
Good.
It's very small,
Yes.
well circumscribed.
Perfect.
So I would think we're dealing, what was that?
You think it's benign, basically?
Oh yeah, it's very small, well circumscribed, symmetrical. So I think it's some kind of benign neoplastic process.
Good. What part of the body are we on here?
It would be hard to tell, but I'd say maybe the face.
Yeah, good. It's got a little follicle here. There's a tiny demodectic mite in there. I'm not sure. It's got a sebaceous gland here. It's on sun-damaged skin. So yeah, it could very well be on the face. In fact, this is the most common location for these lesions is on the face. So what kind of differentiation? So we're pretty much 80% through small, well circumscribed neoplasm. Now we need to decide what kind of differentiation we're looking at here.
So if we look at the cell types that are proliferating, they look very wavy. You see those thin, spindly nuclei. So once again, I think we're dealing with something of neural origin, like a neural sheath tumor.
Yeah, so it's another one of these neural neoplasms. Now, if you just look at this, remember what we just looked at a second ago, do these cells look closer to what we just saw with the amputation neuroma, the accessory digit due to traumatization and whatnot in utero, and you get a residual traumatic neuroma? Or did it look more like the schwannoma that we saw a couple of slides ago?
The latter, more like the Schwann looking cells.
Okay. Well, we can go back and just compare. Let's just do that. So here's that one. Go to high magnification. Okay, so fix that in your brain.
Oh yeah.
And then let's go back to the schwannoma and fix that in your brain. Does this have more of a myxoid stroma with more of a loose, wavy, bubblegum-like morphology as opposed to the one we're looking at now?
You see the waviness a little better on the second one.
Yeah, I think so too. And I think this one has got a little bit, it does a different stroma. This one doesn't really have the myxoid stroma, so to speak. So when you're thinking of like schwannoma or neurolemoma or neurofibroma, they tend to have more of a myxoid stroma. They have more loose myxoid stroma with mucin, mast cells. If you ever biopsy a neurofibroma, they tend to bleed more than, say, if you biopsy like an accessory digit or one of these. So these don't have that loose myxoid stroma. You're not going to find too many mast cells in this lesion. So this has got more of the actual nerves, if you will, just like the traumatic neuroma had more axons and more of the actual nerve twigs as opposed to mostly Schwann cells. So if you did a neurofilament on this one, this would be positive too, just like the last one. If you do a neurofilament on a schwannoma or a neurofibroma, it's going to be mostly negative because they don't have the actual axons in there to the same degree. There's some, but not nearly as many as this. So here I think we're looking at mostly axons. So I think this would be more in the neuroma category as opposed to schwannoma, neuralemoma, sheath category.
Right. So I think you see that kind of the retraction or the I think it's called clefting. It's
Yes.
almost separating from the dermis, and then you see it forming those really nice little bundles of the
Yes.
nerve cells. So putting that all together, I think this is what is palisading encapsulated neuroma.
Good, exactly. Palisaded encapsulated neuroma. Not something that you learn about too much in your residency. Have you heard this much from your clinic on the wards and stuff like that? I mean, you're in a clinic, you're attending, say, oh, that's probably a palisaded encapsulated neuroma.
No, I can't say.
Probably not. You know, the clinicians generally don't think about this. They see this on the head and neck area. They're slightly translucent papules. They get submitted to us as rule-out basal cell carcinoma, rule-out sebaceous hyperplasia, sometimes fibrous papule. So this isn't something that's taught very well from a clinical perspective. So just remember, it usually looks like those lesions. So put it in your differential diagnosis. And then your dermatopathology teacher will say, you're really smart that you thought about it, because they do come up every now and then. So notice this. So this is a neuroma as opposed to the other one. And it's palisaded, like you said. It's got these little sort of cells are arranged in these little sort of like, they're not exactly palisaded as much as GA, for example, but you can see these cells are kind of forming these little whorls, if you will. It's not really encapsulated, but it's got that cleft around it, and it's a neuroma. So it's an okay name, but it sort of makes sense. Now, what's another setting that doesn't look usually exactly like this, but what's another situation where you can get neuromas in dermatology?
Kind of like we just talked about the Morton's neuroma with the high-heeled shoes.
Those, traumatic neuroma, Morton's neuroma, but there's one other setting that you need to just know about that has neuromas associated with it that you probably will be asked about somewhere on the board examination. They probably won't show you a histology of one of those and expect you to say, that histology means this, but they will probably ask you about a condition where you can get neuromas that can be a genodermatosis.
Like neurofibromatosis, but that would be neurofibroma.
Yeah, those are more neurofibromas. So we're talking about neuromas.
I'm not sure.
Anybody know? The multiple mucosal neuroma syndromes, you know, Sippel's syndrome and those kind of things that are associated with parathyroid disease and all that stuff. So make sure you know that, because that's something that they could ask you about, those multiple mucosal neuroma syndromes. I think there's about 2 or 3 of them. There's a type 1 and type 2, and I don't remember the other name. I know one is Sippel, but they're associated with, you know, endocrine problems. They can get other kind of cancers and things. So you definitely need to go back and just bone up on that so you won't miss that. They're not going to ask you the histology of that, but you probably will get a question about multiple mucosal neuroma, because they love to ask about genodermatoses, things where dermatologists can recognize something and then, you know, help the patient out. So make sure you know about that.
Thank you.
You're welcome. Who wants to give this one a go?
Hi, my name's Taylor. I'll take this one.
Okay.
So it looks like we have a punch, and from scan, I would say this looks neoplastic. It's pretty well circumscribed throughout both the superficial going into the deep dermis.
I agree. It's kind of got a wedge-shaped kind of architecture also, doesn't it?
It does.
And that tends to favor benign too. And then what if we draw a line right down the middle of it?
I think it looks very symmetric.
Yeah, I totally agree. So yeah, it's just got all the cardinal features. This might actually even be an excision biopsy, which is a punch is a type of excision, but it might have been a larger lesion that they just totally excised. So we think it's neoplastic, we think it's benign. And then the next step is what kind of differentiation is exhibiting.
Yeah, so contrasting from the last few cases where we had more spindled or wavy, I think these cells look more epithelioid.
Good.
They have like a central ovoid nuclei and then kind of like large, very eosinophilic cytoplasm,
Okay.
like cytoplasm around them.
Anything about that cytoplasm that kind of piques your interest a little bit? It is pink and whatnot, but what about the texture of it?
Yeah, it's very granular.
Yeah, yeah. And that's important to recognize that. I mean, this is really, these are little granules inside there. It's a beautiful example of that here. So what's the diagnosis?
Yeah, I think this is a granular cell tumor.
And I think you're right. It's exactly a granular cell tumor. And these are basically benign lesions. They very rarely can be malignant. What kind of ethnicity was this patient, do you think?
I am not sure. There is a lot of pigment in the basal layer.
Yeah, yeah. And so why is that important in this situation? What's one of the most common demographics of patients that get granular cell tumors?
I'm not sure.
They're very commonly seen in Negroid African-American patients. It's very commonly seen in that setting. So it's one of the more common benign lesions that we see in Black patients. Most neoplasms that we see, like basal cell, squamous cell, cirrhosis in Caucasians, but in Black patients, they very commonly get granular cell tumors. So it's not, I think they may actually be more common than in Caucasian patients. You can get them in both, but it's just, they're very commonly seen in Black patients. So that's something just to be aware of. And what's one other site that's very commonly involved with these lesions? Not in this case, but a common location of them.
Yeah, I believe the tongue is.
Tongue is exactly right. They can be multiple. Most of the time they're benign. They usually are painless. Sometimes they can be painful. What's the source of the granules inside these cells?
So I think the cell type is derived from Schwann cells, but as for the actual granule itself, I'm not sure.
The granule is thought to be their lysosomal storage. They're basically lysosomes just kind of filled up, but it's thought to be myelin breakdown product. These cells are sort of trying to make myelin, and something went wrong and they became granular cells. And so this material in here is thought to be sort of precursors or related to myelin protein. So these are thought to be in the Schwannian category also, kind of a neurocristopathy, if you will. And so that's basically, and these are lysosomes. And if you wanted to stain these cells, what would you stain them for?
You could stain them for CD68 for the lysosomes.
Yeah, there's a couple other stains that are really better, actually, that are more specific for this tumor.
S100.
Good. They're strongly S100 protein positive because they're in the Schwannian family. And then if you wanted to actually stain the material inside the cells, what stain highlights these?
Would it be the myelin basic protein?
You probably could do that, but they stain positive for PAS. So those little granules are PAS positive, and the cells are S100 protein positive. Now, one other thing about granular cell morphology, it can also be a reaction pattern. And so a lot of people think this thing is kind of the Schwann cells sort of went wild, if you will. They're not performing properly, forming nice myelin around the individual nerves. They just kind of form these bizarre cells that accumulate, and they get chock full of this myelin breakdown product here. So you can kind of get this as a reaction pattern in a number of other types of tumors also. So there's a granular cell atypical fibroxanthoma. There's a granular cell angiofibroma, granular cell fibrous papule. There's a granular cell leiomyoma that we can see on occasion. So there are a number of different other tumors that can give you granular cell findings in there, but it's not really a granular cell tumor itself. So just be aware that sometimes you can actually get granular cell histology, but it doesn't actually mean that it's a granular cell tumor itself. The tongue, years ago, before we really had immunoperoxidase stains, we didn't know what these cells were. And they used to get called granular cell myoblastoma because they thought, because, well, gosh, these are probably muscle and it's breakdown products of muscle here. And we now know that's false, but because they were occurring on the tongue, a lot of people thought they were actually from a muscle derived lesion, but now we know that's incorrect. Great. It's a beautiful example of that, by the way. So if you get something like that on the board, that's probably the kind of slide you're going to get because it's really pretty classic. This one's kind of an interesting one.
Yeah, I can take this one. It's Eugenio by Go by Kenny. So I guess starting off, it looks to be pretty well circumscribed. There's no like obvious kind of like epidermis for this one.
Okay. What kind of biopsy do you think they did here?
I mean, it looks kind of almost like a shell. I don't know if it was like a nucleated or.
Yeah, exactly. Same ball game. It's just like the one we had a couple of slides, like the schwannoma. This thing probably felt like a subcutaneous nodule, if you will. And they said, probably a cyst or something. And so they did the same thing. They just took a linear, incision and they just kind of shelled it out. Exactly. So that favors benign, not always, but favors it.
And so from like low power view, it looks like there's like these spindled cells almost like in like the sheet-like pattern. Almost looks like there's like fascicles between them.
Okay.
And like this like fibroceptation with like separating some of the nodules.
Yes, people call that a trabecular pattern. When you see these kind of strands of collagen between the neoplastic cells. Now, trabecular, some people call like Merkel cell carcinoma trabecular carcinoma because it has that pattern a lot, but you can see that sort of finding in a lot of different neoplasms. And basically what's happening is it's just the neoplasm really isn't making collagen. It's just that the residual collagen sort of stays between the individual neoplastic cells that sort of separate it like that. So did you think this was, what kind of differentiations do you think we're looking at here?
So I don't know if these were more kind of like spindle-shaped epithelioid type cells.
Definitely are some that are spindle here.
Yeah.
What about these cells over here, or these structures here?
Yeah, and so it looked like there was like round, small, like capillary-sized vessels as well.
Yeah. Good. And they're sort of almost forming these little lobular proliferations. They're not quite glomeruloid, but and it's not, you don't have a stroma where there's some edema and there's some inflammatory cells, like for example, in a pyogenic granuloma. So you've got a more kind of almost a little lobular capillary proliferation associated with some cells that have more of a spindle cell morphology. And what about the cytology of these cells? Any atypicality?
I don't see too much atypia.
Yeah, not atypical at all. Look pretty bland. No real pleomorphism, nothing that would make us worry about cancer here. So we think we've got a benign lesion with vascular differentiation. So do you have any idea about the diagnosis?
I don't. I have a few kind of just for differentials. I mean, I was just thinking under like the vascular chapter, things that could be maybe, so like a Kaposiform angioendothelioma or
well, those things are thought to be malignant in a way. They're
yeah, really, that's true.
They have a lot of spindle cells, and they're very pleomorphic and have some very irregular vascular channels with some large endothelial cells that protrude into the lumen. So probably not that. And those don't shell out either. Those are, as you know, what entity is associated with Kaposiform angioendothelioma? What disease is associated with that?
Kasabach-Merritt.
Yeah. And the reason, they get that huge, usually it's a gigantic vascular lesion on a kid's leg. It's swollen, they platelet trap. So that wouldn't be a very likely idea. This is probably second half of your third year diagnosis because it's kind of a fairly unusual pattern. If I showed you this in a different setting, what am I pointing to right here?
Adipocytes maybe, or?
Yeah. And notice how these are kind of blending somewhat imperceptibly into the vascular component. Does that give you a clue here? And what if I told you this was exquisitely painful? That's why the patient wanted it out.
Oh, huh.
if I showed you this same entity, but 90% of the lesion was fat and 10% was the blood vessels, what would you call it?
Yeah, like an angiolipoma.
Yeah, angiolipoma. So what this is an angiolipoma where the angio component is comprising the vast majority of the lesion, as opposed to most angiolipomas where the fat comprises the vast majority of the lesion. But if you go back and ever look at just a regular old garden variety angiolipoma, start looking at the blood vessels, they look exactly like this. They're very round, they're very homogeneous. There may be some spindle cells associated with it. There's no mitoses, no pleomorphism, no atypicality, no large blood vessel, no large endothelial cells protruding into the lumen, like you see with a Dabska tumor or hemangioendothelioma like that. And you get a lot of them are kind of filled with these little erythrocytes here. They're not really thrombosed, but they have a lot of red cells sludged in the blood vessels. So that's a fairly common finding of these lesions. So this is a sort of the lobular capillary tufted appearance of the angiomatous component of an angiolipoma, where it was kind of mostly the angio. Kind of an interesting lesion. I don't think you'll get this on the board examination, but I think it's important to kind of recognize that this is a benign vascular lesion, not angiosarcoma. It's not a pyogenic granuloma. It doesn't have that kind of stroma. It doesn't have any inflammation in it. And it's got this, it's deep, and it was a painful lesion. So if you got into the vascular category, that's great. It's just, this is just kind of an interesting example of this to show you what the angiomatous component of an angiolipoma looks like when it's really the predominant component of the lesion.
Cool.
Any questions or comments about that one?
No, thank you.
You're welcome. Now we're going to totally shift gears, but this is a great case also that every dermatologist needs to know.
Hi, my name is Jessica. I can take this one.
Great.
So right off the bat, this looks like a really deep shade. I'm sorry, a really deep punch.
Yeah, and this is a fantastic biopsy. I mean, gosh, they said, gosh, there's something going on deep.
Yeah.
They probably took that punch and put it all the way into the plastic and then kept pushing. So.
And then up higher in the epidermis, I didn't really see much going on, as well as in the dermis. There's a little bit of
all this stuff's normal. So the action's going on down here.
Mm-hmm.
So when you get action in the fat, what's the diagnosis basically?
Paniculitis.
Yeah, paniculitis. Good, paniculitis. Now, how do you approach paniculitis?
So first you would
logical way. So it's good because if you have a good logical method, you can work through it and make the diagnosis most of the time.
Mm-hmm. So first you would want to know if it's septal or lobular.
Good. Which of those do you think's going on here?
So I think this one is lobular.
Perfect. Perfect. So here's the septa, and that's pretty much normal. Here's the lobule, and it's totally abnormal. Something's going on in that lobule. So we're in the septal, lobular mostly paniculitis. And, we usually say lobular mostly or septal mostly, because sometimes you get a little bit of septal involvement in lobular paniculitis. And if you get a septal paniculitis like erythema nodosum, sometimes you get a little bit of bleed over into the lobule. So it's not always perfect. Sometimes it is perfect, where it's purely septal, purely lobular. But we usually like to say septal mostly or septal or lobular mostly. So here we've got lobular mostly.
Mm-hmm.
And what's the next thing you look for?
And then you want to know if there's vasculitis or no vasculitis.
Excellent. And is there vasculitis here?
No, I did not see any.
Now there's a pitfall in that, because if you don't sample the blood vessel, you may miss it. So, you may miss it. And so you say, well, there's no vasculitis, at least in these sections. But anyway, we've got a lobular mostly paniculitis without vasculitis. Anything else here that helps you?
So the type of inflammatory cells.
Good. What kind of inflammatory cells have we got here?
I saw a lot of neutrophils.
Neutrophils. Excellent. And basically, I don't see any histiocytes. I don't see any eosinophils. And then what about this stuff going on here?
Yeah, so I thought that was like some of it was necrosis and then some was like saponification.
Yeah, exactly. Do you see this dark purple here? That's probably actually some calcification. What's going on in saponification? What's the chemical reaction in saponification? So if you want to make soap and sell it and put some fragrance in there and have a soap business, how do you do that? How do you make soap?
I'm not sure exactly how you would make it, but I know it's basically like the fat that's like turning into soap. And I think like in this process, it's like amylase and lipase that would like do
That's
that.
exactly right. That's exactly what happens. You have circulating amylase and lipase. It goes in. So this is actually it's not really truly a primary paniculitis. It's really a circulating chemical that damages the fat and turns it into soap. And then all this stuff comes in here secondary and say, hey, what's going on here? We have soap in our body. That's something we want to get out of here. So it's an inflammatory reaction comes in secondarily to this. So it's actually primarily an enzymatic destruction of the fat. And the saponification process is basically stearic acid, which is one of these large chain fatty acid esters or whatever acid. And then if you have calcium that comes in, it formed with the chemical reaction, you get calcium stearate. So that's actually what we're looking at here. It's basically calcified lipid that forms a soap. And then this stuff comes in here secondarily. So this is pancreatic paniculitis. It's pathognomonic for pancreatic disease. So if you see this, you got to go find the pancreatic disease. Sometimes it's chronic pancreatitis, acute pancreatitis. Sometimes it's pancreatic cancer. Sometimes we had one case a number of years ago that we saw this and we said, this is pancreatic paniculitis. And the internist said, no, it's not. The patient doesn't have any pancreatic disease. They couldn't find any elevated amylase or lipase. Turned out the patient had a tiny little fistula between their gallbladder and their pancreas, and they were releasing just enough amylase at low level to get pancreatic paniculitis just in a focal area. And it was just a few little lesions. So they found it and they took out his gallbladder and he's cured. So it means they have to have circulating amylase and lipase to cause this. So once you see it, it's pathognomonic. So board is this could be something they could show you on the exam because it's pathognomonic. So once you see this classic stearate fat in the changes like this, you make the diagnosis. So that's great. So congratulations. This is also a beautiful example of something, and this could very, very easily be on your exam.
I can take this one. My name's Caroline.
Great.
So,
and it's a low power diagnosis here, by the way.
okay. I think, yeah, from scan, looking at this lesion, some asymmetry stuck out to me, and a lot of spindle cells.
So we're
And
neoplastic, right?
yes, I
Yeah.
felt that this was neoplastic, and then with the asymmetry.
Yes. Notice how asymmetrical this is compared to the other stuff we have. And we just had this probably was a deep punch or maybe an incision of this. And what's another thing that favors malignant here? We don't know the circumscription. It looks very poorly circumscribed, right? It's going all the way down to the fat. This thing is probably like the tip of an iceberg. This may go way deeper than this. It may go down the fascia for all we know. So it's poorly circumscribed. It looks fairly big. What's one other feature here that favors malignant at low magnification?
I think the ones that you said, like the invasion into the fat, I'm not sure.
So that's basically notice how it's bottom heavy versus top heavy.
Okay.
So things that are
Right.
that like the top, they kind of float to the top. Those tend to be benign, not always, but they tend to be. If they're mostly bottom heavy like this, they're more likely to be malignant. So that's good. So those are just things at low power that tell us malignancy. Now, you said spindle cells. What's something about the pattern here that you should instantly think about the diagnosis based on what we're looking at right here?
Yeah, the fat trapping, the way the spindle cells are kind of wrapping around the fat and infiltrating into the fat, makes me think of dermatofibrosarcoma protuberans.
Perfect. Good, excellent. It should make you think of that. So if we're looking at slides and this comes across the microscope and it's low power, I'm going to say, boy, that looks like a DFSP almost immediately. And then we're going to do higher magnification and we're going to look at it and wow, look at this. What's the classic pattern that we talk about in DFSP of these spindle cells?
So you can see like the story form pattern.
Yeah. What does storiform mean? Does that mean like telling a story to your kids or something? Or what does that mean exactly?
Kind of like the swirling of the spindle cells.
Yeah, it's kind of a basket weave pattern. The cells are really, they're palisading like you see here. It's kind of like that palisading encapsulating neuroma a little bit. So they look like they're kind of almost like a whirlpool of these cells, if you will. Beautiful example of that here. This is about as good an example of DFSP that you're ever going to get. So the board's probably going to show something like this if they're going to show it to you, because this is just a beautiful classic example. And this is the honeycomb pattern, like you said, the fat trapping where the cells are percolating between and among the individual lipocytes. There just really aren't that many neoplasms that really give you that pattern like this. And the cells really are not that atypical themselves, are they?
Yeah, I did not see a lot of mitoses on high power or atypical cells.
Yeah, so this is an entity that's malignant primarily because of its local effects. The fact that it goes deep, can get into nerves and muscle and cause all sorts of problems like that. So basically, they don't necessarily have to metastasize to be malignant, but if you don't cut these things out and get rid of them, they can recur over and over again. And eventually they can degenerate into a true fibrosarcoma, not just a DFSP, that kind of low-grade sarcoma that doesn't really usually cause problems except locally, but they can eventually become very much more atypical, and then they can end up killing the patient. Now, the board might ask you some molecular genetic information about this lesion. So what is the molecular genetic abnormality that causes dermatofibrosarcoma tuberans? And what drug can be used to treat the lesion? There is one mitotic figure here, but there's not very many.
Oh, I know it can be due to a mutate or a fusion of like the COL1A1 gene. But in terms of like the
what does it fuse onto? It's basically
the PDGF
platelet-derived growth factor. Good, excellent. So you get that fusion, and that basically causes these cells to start proliferating dramatically. So that's actually what happens in these lesions. And a lot of the molecular geneticists, they go in and look for that genetic abnormality. And actually, if you look at a karyotype, they actually will get a ring chromosome in many cases that goes along with this. You actually see a ring chromosome that's associated with this thing when you if you actually do karyotype analysis of the actual tumor cells. And what drug treats this?
I read imatinib or
yeah, exactly. Gleevec works great for this. And so a lot of times what we do is we'll give them Gleevec to try to shrink it down, and then you do Mohs on it afterwards and make sure you got clear margins. So I think that's what a lot of Mohs surgeons are doing. This is a really good tumor for Mohs because you want to make sure that basically what the Mohs surgeons do is they sort of get what they think is clear margins histologically, and then they'll take a margin around that just to make sure, because these things really can be quite subtle. I mean, when you're looking at maybe down at the bottom here and maybe you think you're clear and you see maybe just a couple of these little cells here that look almost like normal fibroblasts, that's still part of the tumor. And so you really want to get almost just perfectly normal skin, especially if you're dealing with an area, say, overlying the galea or something like that. That galeal tissue can look a lot like the tissue of a DFSP, so it can be really, really hard to get out. Sometimes they'll use CD34 to kind of, when they kind of get towards the edge of it, they'll stain it with CD34 and make sure that that's pretty much negative to make sure they've really got clear margins on this. Okay, we have 2 minutes. This is what we didn't do before. Why don't we do this one really quickly? Who wants to give this one a quick go?
I can do this one. My name is Sahira. So I think looking at low power, it looks like a punch. I see a lot of gray purple at the top, which makes me think this is like possibly ciliary elastosis. So maybe on a very sun exposed area, maybe an elderly person.
Good.
And then On the left, it looks like the epidermis has just cleanly split from the dermis. So I thought this fell under the category of like a subepidermal vesicular dermatitis.
Excellent. So what's your next step once you determine that?
Looking at the cells that are present, like the inflammatory infiltrate.
What kind of cells were here?
Neutrophils, and then I saw eosinophils kind of both superficially and deep.
There's a couple of EOs, and yeah, I agree. There's some EOs in here, although the predominant cell here are neutrophils. And so say neutrophils mostly, what are your 2 or 3 most common items in the differential?
So neutrophils mostly, I was thinking maybe bullous pemphigoid.
Is that mostly neutrophils usually?
No, maybe eosinophils and neutrophils mostly.
It's usually lymphocytes and EOs, and
Okay.
rarely neutrophils. But if you get the neutrophilic ones like dermatitis betiformis, you sometimes get eosinophils in that. So usually not too many neutrophils in pemphigoid, but the neutrophilic ones like DH and LIGA, you often do see some EOs in that. So this is an older person, like you said, absolutely correct. Notice that the neutrophils are lining up kind of in a broad zone beneath this blister. It's a real blister because there's some neutrophils in the blister space. So what's the most likely diagnosis?
Maybe dermatitis herpetiformis.
Well, it could
Or
be
linear
DH.
IgA.
Yeah. I like linear IgA a little bit better here because number one, it's an old person, usually DH is in younger people. And also you get this diffuse linear involvement, if you will, of the neutrophils, as opposed to just being just at the tips of the dermal papillae. Now, obviously, you confirm the diagnosis with immunofluorescence because you can get DH can give you this pattern sometimes too. But just looking at this alone, older person, maybe they're on a medication and they got this, maybe they're on vancomycin for an infection or something like that, and then they end up getting linear IgA bullous dermatosis. So this is a good example of that. I wanted to quickly go over this one because it's been sitting in the queue for the last month or two, but that's a nice way to work through that. And you're absolutely correct. The other, you just know the other differential diagnoses of things that give you subepidermal blisters with neutrophils, the most common one probably would be bullous lupus can give you neutrophils, but that would not generally tend to give you EOs. So if you see neuts with some EOs, think DH or linear IgA bullous dermatosis. Okay, very good. Thank you guys for participating, and we will see you guys next month.